All right, so we'll start with, so this is the concept map. And you can see I actually combined, chapters here. So this is fetal development and maternal changes during pregnancy, okay? So I start with, physiology, normal physiology, and then we kind of talk about what happens after that. This part right here is kind of similar to what I'd like group 1 to present. Okay, because they're talking about fetal development, but one thing that's not here that I want you to present is the circulation. Okay. But this is, so I'm not gonna go over this, but this is something that you guys can use as a reference. Just don't plagiarize, okay? So what I'm talking about here, I'll start here with the blastocyst stage. What I'll be talking about is what hormones the placenta secretes, comes out of it, that changes what happens to a woman when they're pregnant. Okay, so it starts with the fetal development. So once the fetus develops and the cells develop, when it gets to the blastocyst stage, there's 2 layers of that cell, and the outer layer, it becomes the trophoblast. And then the inner layer becomes the embryo, which becomes the baby, and then the amnion, which becomes part of the amniotic sac. Okay. The amniotic sac is that sac where the water is at. Like if you ever hear a woman say, oh, my water broke, it's because they have like this bubble, this sac where the baby is contained in, and there's water in there. So the baby's floating in that. Okay. The trophoblast becomes the chorion, and that becomes the placenta. So the placenta is this organ that only pregnant women have that provides the nutrition for the baby. So as the fetus is growing, the placenta is growing, it attaches to the fundus of the uterus. The fundus is the top of the uterus. So it attaches to the fundus of the uterus, it grows, and then it connects to the mom's blood vessels. And then it starts to develop its own blood vessels connecting to the baby. Okay. So apart from nutrition that it provides or circulation that it provides to the baby, it also secretes a lot of hormones, which is what creates the changes in pregnancy. Okay. So that's what we're going to be talking about. Before the placenta matures, it's the trophoblast that releases HCG. HCG is human chorionic gonadotropin. Okay, human chorionic gonadotropin. So that hormone is the same hormone that we check in the blood to see if the patient is pregnant. Okay. This is also the same hormone that creates nausea. So moms become nauseous when the HCG increases, but HCG is released as the fetus is developing, is growing. Okay. Initially, again, that comes from the trophoblast. Now, once the placenta is fully formed, that takes over the function of the trophoblast. There's no more trophoblast because it has matured into the placenta, right? So now the placenta releases the HCG. Okay, so that's one of the hormones that is released. So the function of the HCG or the chorionic gonadotropin is it preserves the corpus luteum. So basically the shell of the egg, the embryo, right? And that maintains the endometrial lining. The endometrial lining is the inside of the uterus. That's the inside wall of the uterus. If that lining sheds, the baby will die. Okay. If the endometrial lining is not intact, the fetus that is attached to it will shed away. So the mom will have a miscarriage. So it's very important that the HCG maintain the endometrial lining because that maintains pregnancy. Okay. But again, if there's a lot of HCG, so that's going to cause nausea. And then we'll talk about hyperemesis gravidarum later on. That's going to be in your unit exam 1. So I'll come back to that. We're talking about just normal right now. Okay, so HCG is responsible for what symptom in pregnancy? Nausea, okay, and vomiting sometimes. Progesterone is the other hormone. So this is again going to be released by the placenta. So it's responsible for smooth muscle relaxation. So which muscle do we want to relax during pregnancy? The uterus, right? The myometrium. Endometrium is inside, the myometrium is the middle layer, where that's the muscle that will contract. What happens if the uterus contracts and the mom is pregnant? What happens? The baby will come out, right? So we don't want the uterus to contract unless it's time to deliver the baby. So the job of one of the jobs of the progesterone is to relax the uterus so that it doesn't contract. So therefore, you keep the baby inside, right, until it's ready to come out. However, because it cannot choose which muscle to relax, it also relaxes the GI system. And that is where other symptoms in pregnancy come from, okay? So it has that purpose with regard to the uterus, but because it also relaxes the GI system, so a couple of things happen. One of the things that happen, let's start with here, is when the GI system is not moving, there's decreased peristalsis, right? What is peristalsis? It's movement of the gut, right? Of the GI system. That's how the food moves down, right? So if there's decreased peristalsis, then the food or the time doesn't move as fast. And so what happens in the large intestine is it stays there longer because the large intestine is not moving as fast. So the longer it stays in there, then the more the large intestine is going to absorb water from the stool. And so what happens? Mom gets constipated. Okay. So in pregnancy, we want them to drink at least 3 to 4 liters of water a day. Okay, 3 to 4 liters of water a day. Okay. So in the stomach, that's also going to cause decreased gastric emptying. So again, gastric emptying is when whatever you eat goes into the stomach and it can squirt it into the duodenum, right? That doesn't happen as fast. And so what happens? The mom feels bloated, right? So you see, this is color coded. You see the red here or the time, right? So mom feels bloated. She feels nauseated. She feels like she's going to vomit because her stomach is always full. Okay. And she may also get acid reflux, GERD. Okay. Because it's always full. If this mom also is obese is BMI that is greater than how much? You know, that's 30, right? If you have a BMI greater than 30, or if this patient already has a weak LES is lower esophageal sphincter, that's the sphincter above the stomach. That is what causes GERD, gastroesophageal reflux disease. If you have a weak LES, you get reflux. So if they're coming into the pregnancy already with those issues, then for sure they're going to get reflux. If they have hiatal hernia, anybody know what hiatal hernia is? So hiatal hernia, so this is the stomach, right? This is the LES. In hiatal hernia, this part of the stomach, the fundus, it permeates out here, so on the esophagus. So then food gets stuck in there, right? And so then mom refluxes. So what causes that? If there's a lot of abdominal pressure on here, it pushes the stomach up. Okay, baby's abdominal pressure, right? When there's a baby in there, the larger the baby is, the more pressure in the abdomen. Obesity causes abdominal pressure. If you're wearing a lot of tight clothing, that causes abdominal pressure. Okay, so anything that is pushing here, it can push the stomach up, causing hiatal hernia. Okay, so if they have that risk, they'll have acid reflux as well. And then in the gallbladder, so there's also going to be decreased emptying of bile. from the gallbladder, right? What is the function of bile? The bile, what does bile do? It emulsifies fat, right? It emulsifies fat. So the gallbladder stores the bile. And when you eat fatty food, the gallbladder starts spasming to release the bile to the duodenum, right? But if it's relaxed, it's not going to squirt the bile into the duodenum. So what's going to happen is the bile is going to clump. When the bile clumps, it forms a stone. So there's a risk of cholelithiasis. Lithiasis is stone, right? It's a gallstone. So pregnant women oftentimes will get gallstone because of this issue, which is from the progesterone. Okay, so they're high risk for that. Okay. And then the hemorrhoids part on here is because the greater the abdominal pressure, the more pressure there is on the veins, right here. Hemorrhoids is caused by they're like varicose veins, if you want to think of them that way. Varicose veins in the anus. Okay, there's a portal vein that runs from your esophagus all through your gut to the rectum. So if there's a lot of pressure here in the abdomen, so there's a decreased flow back of the blood to the heart, right? Venous flow back to the heart. So then the blood gets stuck in the rectum, causing hemorrhoids. And then the more concentrated they are, the more hemorrhoid they're in also. Okay, so that's why moms, pregnant women may have hemorrhoids. Okay, so that's another effect of pregnancy. Okay, so that's progesterone. So what does progesterone do? Relaxes the smooth muscle, right? Is that good or bad? That's good for the mom, right? For the pregnancy, but it has its own effect, right? So now estrogen, whenever you think of estrogen, I want you to think of increased blood supply. Okay, so increasing blood supply. So estrogen is responsible for the breast getting engorged because the tissues become hyperplasia, they become swollen, right? It's responsible for increasing blood vessels. So you actually will produce more blood vessels when there's estrogen. It's increasing vascularity. So in the HENT, that causes mucus congestion. Okay. When there's a lot of blood flow, there's a lot of congestion. So a lot of the moms who are pregnant, they get a lot of sinus congestion. It's because of the estrogen. Okay. And then because of the nasal congestion, and there's a lot of new blood vessels again, so they get epistaxis. What is epistaxis? Nosebleeding. Because these new blood vessels that form, they're not as strong as the old ones, so they burst easily. So that's how they get epistaxis. Same thing in the gums, they can get gum bleed easily, and because of the fresh blood vessels that have formed during pregnancy. They may get rhinitis, which is just a lot of runny nose, right? Rhinitis and runny nose. So HENT and breast engorgement, those are caused by estrogen. And now because there's a lot of estrogen that comes from the placenta, in the brain, in the anterior pituitary, there's going to be a decreased FSH and LH, right? What is FSH and LH? What is that for? Follicle stimulating hormone and luteinizing hormone, right? They come from the anterior pituitary. They will tell the ovaries in a non-pregnant person, right? They will tell the ovaries to produce egg, right? And they have fertilizers, right? But because estrogen is coming from the placenta, it brings a feedback to the brain saying, hey, I don't need any more FSH and LH because we have enough estrogen and progesterone. So then the brain increases the FSH and LH. Now, but what happens is it sends another feedback to another endocrine gland. Okay, and it says, hey, you don't have a lot of FSH and LH. Oh, okay, well then I'm gonna produce more aldosterone here in the adrenal gland, in the adrenal cortex. compensate for that. So then mom gets a lot of adrenal, a lot of aldosterone and cortisol. Aldosterone is mineralocorticoid. So this is a steroid. Okay, this is an endogenous steroid. And then cortisol is glucocorticoid. Right, so they both come from the adrenal cortex. So what does an increase in aldosterone do? When there's an increase in aldosterone, there's an increased absorption of fluid, of water. Okay, whenever aldosterone is involved, these two things happen. You're peeing out more potassium, but you're absorbing more water and sodium. Okay, so what happens when the mom is absorbing more water and sodium? The blood volume, okay, by 30 to 45% at term. What is normal blood volume? How much blood do we have? How many liters of blood do we have? No? Yeah, 5 to 7 liters, right? So then you increase that by almost half, right? So it increases the cardiac output 30 to 50%. Okay, so you get another 2 to 3 liters of blood, right? So then that creates a little bit more hard work for the heart of the mom. So you might hear a slow murmur. Okay, a murmur is like a swishing sound when you're listening to the heart. Like you hear the love dub, right? Love dub, love dub, love this, love this, love this, love this. The swishing is a murmur. And it's normal. What that is just because you're hearing the extra blood that's being dumped into the ventricle. So that's what's causing the murmur, okay? You might also hear an S3. So an S3, S1 and S2 is closing of the valves, right? S1 is closing of the AV valves, S2 is closing of the semilunar valves. When you hear an S3, that means that one of the valves is closing late because there's so much volume that it needs to let through first before it closes. So you might hear love instead of love. Okay? Normal. Okay. So another thing that happens because there's a lot of blood volume is the concentration of the RBC in the blood becomes less, right? It's not that they don't have enough RBC or hemoglobin, but there's just a lot more fluid. So they're gonna look like they have dilutional anemia. Okay. What is normal hemoglobin? Hemoglobin 12 to 18. So in pregnancy, it's common to be in 11s. Okay, and there's nothing wrong with them all the time, but it could be just because it's dilutional anemia. There's so much water that it looks like it's diluted. It looks like there's less RBC in hemoglobin. Does that make sense? Okay. So another possibility that could happen is if the kidneys swell up and the ureters swell up, then flow of urine could be decreased. And so there is a possible risk of UTI associated from that. Okay. That's only one of the reasons that pregnant women can get a UTI. A lot. There's many reasons. This is just one of them. Okay. They also will urinate a lot. So there's a test question that you guys might encounter that talks about when does a pregnant woman have increased urinary frequency? And the answer is actually all throughout the pregnancy. So initially in the first term of pregnancy, it's because of the hormone, right? The estrogen is increasing the urinary frequency. As the baby comes to term, the baby gets bigger, it's pushing on the bladder. So then that causes the mom to feel like I need to pee, every so often. So then there's also increased urinary frequency from that. Okay, so when you're teaching a mom, and they ask you, well, when am I not gonna have to pee a lot anymore? When you're not pregnant. Okay, so during the entire pregnancy, you will have increased urinary frequency. Okay. I'll come back to this maternal hyperglycemia here. Let's go to, so again, here's FSH and LH that comes from the pituitary gland. And so other hormones are triggered from the pituitary gland. So oxytocin comes from the posterior pituitary. There's only two hormones that come from the posterior pituitary, the oxytocin and ADH. ADH, what does that stand for? Anti-diuretic hormone. What is the other name? Very good, vasopressin. So what does that do? It reabsorbs water in the kidneys. Only water, no electrolytes. Okay, we already have the aldosterone absorbing water and sodium, right? Increasing the volume. This further increases the volume. So this contributes to more volume as well. What about oxytocin? Oxytocin comes from the posterior pituitary. This doesn't increase until the baby is ready to step away. Okay. So what oxytocin does is it's going to increase the uterine contraction. Again, it should only happen when the baby is ready to be delivered at term. So then what it's going to do is increase contraction of the uterus so the uterus can push the baby out, right? It also is responsible for release of milk. Okay, it doesn't produce milk, it only releases milk. Okay, oxytocin is so strong that when a mom hears a baby cry or thinks of the baby, she releases milk. Okay, even when the baby's not dead. Okay, so that's the job of oxytocin. And then from the anterior pituitary, we also have this melanocyte stimulating hormone. What is melanin? Pigmentation, right? So because of the changes in the hormones, this is triggered, and this is called by HPL. I'll come back to what that is. So it increases the MSH from the brain, and so in the integumentary system, these are the signs that you will see. So there's a lot of darkening of the skin of the mom, right? In the face, it's called chloasma. So they have like this kind of dark rash on the cheek. That's from MSH, chloasma. They have linea nigra on the abdomen. Linea nigra is that line on the middle of the abdomen, that dark line, in the middle of the abdomen. They're going to have a lot of stretch marks, striae gravidarum, stretch marks on the side, okay? And their areola, which is this, you know, the circumference of the nipple, gets darker and even bigger, like this big, right? Sometimes. And then your axilla gets dark, this gets dark, all of the inguinal fluids get dark. Okay, it's not dirt, it's the hormone. Okay, so that's all caused by MSH. Okay, but that is why they have all these darkness that happens. There's also hyperpigmentation somewhere else. I'll talk more about that later. So that's estrogen. So what is the key thing that you remember about estrogen? Increased vascularity, congestion, right? And then melanocyte, MSH, is all the darkening of the skin, right? So there's a couple more hormones. One of them is HPL. So I want you to think of HPL and prolactin together. Okay, so human placental lactogen is HPL, and then there's prolactin. So in pregnant women, prolactin comes from the anterior pituitary gland, right, in the brain. Here, it's coming from both, but it's mainly coming from the placenta. Okay, so the placenta produces prolactin. That's going to help the mom form milk. So prolactin forms milk. Oxytocin releases the milk. Okay, prolactin forms the milk. Oxytocin releases the milk. HPL, human placental lactogen, develops the breast for lactation. Okay, but here's another thing with these two hormones. They actually affect the mom's insulin level. Okay, so when there's increased HPL, there's a decrease insulin sensitivity. What does that mean? The mom's cell are not gonna recognize its own insulin. What is insulin for? To lower the sugar, right? So when insulin is released, it takes the glucose from the blood, right? It opens the insulin receptors of the cell. It takes the glucose from the blood to the cell. When there's decreased insulin sensitivity, the cells don't open up to insulin. So where does the sugar go? In the blood. It stays in the mom's blood, okay? So a pregnant woman will innately have a higher blood glucose, just as part of how the hormones work, okay? Prolactin, along with HCl, also increases insulin resistance. So decreasing insulin sensitivity, it doesn't sense insulin. Increasing resistance, it doesn't receive insulin. Both of those things contribute to the high sugar. Why do we want a high sugar? Well, there's a baby in there, right? So when there's maternal hyperglycemia, the sugar from the blood is detoured to the placenta of the baby, so that the baby cells can form. Okay, so that's, that's just how nature is. The problem we talk about diabetes next week is if there's other risk factors. That's why moms are high risk for diabetes, because naturally this is what happens already. Okay, so that maternal hyperglycemia goes to the fetus, and once it's in the fetus, then the sugar is normal again, theoretically. Okay. So remember those two, okay, that they are the ones responsible for insulin. There's another hormone called relaxin. So relaxin is a potent vasodilator, but it kind of helps with the dynamics, the hemodynamics of the blood. This is most important at term. So when we say term, there's 42 weeks of pregnancy. Okay. We want them to deliver at 40 weeks. So when we say term, that means they're at 40 weeks. Okay. When we say preterm, that means that they are below 37 weeks. Okay, so term is 37 to 40 weeks. Okay. So when it's time for the mom to deliver, so what this is going to do is it's going to relax the ligaments here, and it's going to soften the cervix. That way the cervix can open up. Okay, when the cervix opens up, then the baby can come through. Okay. Another hormone that is increased at term is prostaglandin. Some of you guys who've been to clinical, we've been exposed to prostaglandin. Prostaglandin does a lot of things. So one of the things that it does is it opens the cervix, and also it relaxes the, it causes uterine contractions. Okay. As a drug, we can, if you've heard of Cytotec or misoprostol, so that's a drug that is given for a couple of reasons. In LND, it's given to, again, force, if you will, the cervix to open up so that the baby can come out. But for that same mechanism of action, it's also given in abortion, like elective abortion, right? For the same reason, to open the cervix so that they can get the food out. Okay, but that's its action. So remember that, because there's gonna be talking about medications later on that are prostaglandin and prostaglandin inhibitors. So depending on what we're talking about, okay? So those are the maternal hormones. Any questions? So I'll quiz you real quick. So which hormone is responsible for nausea? Very good. Which hormone is responsible for relaxation of the uterus? Progesterone. Which hormone is responsible for nasal congestion? Estrogen. Which hormone is responsible for softening of the cervix at term? Relaxin and prostaglandin. Which hormone increases the mom's sugar so that it can be rerouted to the baby? HPL and prolactin. Which hormone releases milk at term? Oxytocin, which hormone increases, which hormone promotes uterine contraction at term? Oxytocin. Very good. You already know it. Let's go home. This will be in your test, hyperemesis gravidarum. So let me put some pointers here. Hyperemesis. Emesis means vomiting, right? Hyper means excessive vomiting. Gravidarum is the term meaning pregnancy, right? Gravida. Gravid means pregnant, right? Arum is the condition of, right? Gravidarum. So in hyperemesis gravidarum, this is a mom who keeps vomiting, maybe due to excessive HCG, right? Or they're just sensitive to the HCG. By definition, past the 16 weeks. Okay, past the 16 weeks. So they have a lot of vomiting. So what happens to this mom if they keep vomiting? Well, obviously they're not taking in food, right? And fluid. So they're gonna have weight loss. Okay, from the loss of fluid, they're gonna get dehydrated. How do we know that they're dehydrated? Their heart rate is gonna be increased. Their sugar is gonna be poor, right? They might have some electrolyte imbalances as well. Okay, the hematocrit is probably gonna be high because the blood is concentrated. In the baby, if this is continuous, it could actually trigger preterm contractions and preterm birth. And if the mom continues to not eat and vomit and, not have nutrition, then of course the fetus is also going to have decreased nutrition. So the baby goes into IUGR. IUGR is intrauterine growth restriction. So what does that mean? The baby is not growing in sound, right? And because of that, the baby becomes SGA. What is SGA? Small for gestational age. What is gestation? So technically gestational pregnancy, right? So gestational age is what's the age of the pregnancy, which is how many weeks is the baby, right? The gestation and the gravida are synonymous. That's pregnancy. Okay, so then if the baby's IUGR, the baby becomes SGA. So hyperemesis gravidarum will lead to small baby. Okay, and then here's another thing that happens to the mom, which might be test question. So because they're not eating, they don't have carbs, right? What do we need carbs for? Energy, right? If we don't have carbs for energy, what do we burn for energy? Fat. So when you burn fat, that's called lipolysis, right? Lipolysis, you're burning fat for energy. What is a waste product of fat? Ketones. That's why there's ketone diets, right? All of those ketone diets, what is it called? Keto diet, right? Ketone. You're intentionally not eating carbs so that you can burn your fat, but then you have waste products from that, which is ketones. So how do you know that the mom is burning fat? There will be ketones in the urine. Okay. Who didn't eat breakfast this morning? Okay. If I test your urine right now, you will be positive for ketones because you're burning fat. Okay. That's just how it is. Okay. So what do we do for this mom? So here's the interventions. There will be test questions about this. So when we're looking at interventions, we want to look at both dependent and independent, right? Independent are things that you can do that don't need doctor's orders for. So you want the mom to not lay on time or lay down at all 2 hours after eating. So if they go to bed at 10, they should, the latest that they should be eating is at what time? 8. Okay, 4 hours is actually more ideal, but 2 hours is minimum, right? Yeah. So at least 2 hours after eating. You want to separate the fluids from the solids. So there might be a test question that's asking you, like giving you options as to you eat now and then give water 30 minutes later, or do you put them all together? So in order for the stomach to not have a lot of content and sugar nausea, you separate the water and solid. So they eat a little bit right now, and then maybe about 30 minutes, an hour later, then they can drink water. Okay, or vice versa. Okay. Your number one choice should be NPO, unless they can tolerate food. Okay. If they can tolerate food, then it's small, frequent meals. But anytime you hear nausea in general, your first choice for a diet should be NPO. Okay, so for test question purposes, you should first choose NPO, unless they can tolerate food. Does that make sense? If they can tolerate food, small, frequent meal. Okay. We know we're assessing the mucous membranes for dehydration, we're assessing the skin for tenting, we're monitoring the eyes and nose, we're monitoring the vital signs for increase in heart rate, for low blood pressure, we're monitoring the weight for weight loss, right, because of loss of fluid. Now, pharmacologically, the first choice are these two drugs here. Okay, so the mom may get vitamin B6, pyridoxine, or doxylamine. So these drugs are safe in pregnancy, and they are anti-nausea drugs. Okay, so these are the two drugs that they will be given first. If that doesn't work, then they can go into Reglan. Reglan is an anti-emetic, but it's also a pro-emetic. So what Reglan does is it actually increases peristalsis. It makes your GI move faster. Okay, that way it's not stuck there. The food is not stuck there, so that decreases nausea that way. That's Reglan, which is metoclopramide, which is generic, right? If that doesn't work, then the mom might need steroid. So steroids may help with that as well. Okay, so that's only for refractory. Refractory means you've given all this already and it's still resistant. It's still ongoing. Okay. If this becomes extremely bad, and again, there's ketones in the urine, right? We don't want ketones in the urine, because if there's ketones in the urine, that means there's ketones in the blood. If there's a lot of ketones in the blood, it can make the blood acidotic, right? The mom can go into metabolic acidosis. Just like this diabetes ketoacidosis, right? Ketoacidosis increasing in ketone. So if that's the case, this mom might get admitted. And in the hospital, they might need to give TPN. What is TPN? Total parental nutrition, right? So in this case, the mom will be NPO, right? They will get the TPN. Obviously, what are your nursing measures? You're going to check the blood glucose, because TPN has glucose, right? You are expecting that the glucose will be high, okay? But you need to monitor that. Typically, also TPN will have insulin, regular insulin in it already to kind of regulate that, okay? How do you know? First question, how do you know that the amount of TPN is sufficient? You check the ketones in the urine. If there's no more ketones in the urine, that means that the mom is not burning fat anymore, right? She's burning carbs now for energy. That means that the TPN is sufficient. If you're giving TPN and there's no ketones in the urine, what does that mean? So what needs to be done? They need to adjust the TPN dose, right? The glucose in the TPN, because it's not enough. Does that make sense? Okay. The two things that you're checking, blood glucose and ketones in the urine, right? The blood glucose is just because you have glucose. The ketones in the urine, check if it's effective. Okay. Question? No? Okay. You understand all that? Yeah.
I know you said that the green is the discontinuing vaccines.
Green is interventions, period.
Okay, so when it's on the left, and then when you go into like medication, you just get a dependent or
Yeah, all meds, because you need an order for it, they're dependent. You're depending on the provider to order it for you. To you. Yeah. So because it should go back down, it's just normal range. Now in OB, if the mom's blood glucose, the NPO, blood glucose, the fasting blood glucose is greater than 90, that's already too high. So then we might consider that, diabetes, and we'll talk about that. Yeah, at 90, ATI, I think, goes by 100, but American Heart Association, or no, American Diabetes Association goes by 90, a little bit more stricter. Okay, good questions. No more questions about this? If they come up later on, just ask. I'm gonna give you one more map, and then we are gonna go into the exam. This is gonna be in the first exam as well. So there's different signs of pregnancy. Okay, I'll make it bigger in a minute, but it's color coded for a reason. Okay, so there's 3 signs of pregnancy: presumptive, probable, and positive. Presumptive, probable, and positive. When we say that it's a presumptive sign of pregnancy, what we're saying is, oh, I think you're pregnant, but I'm not exactly sure. It could be something else, right? So it's just a presumptive, right? We're presuming. So and then I have this all also, if you notice, here's the trimesters of pregnancy. So we divide it into 3 trimesters. So first trimester is 0 to 13 weeks, second trimester is 14 to 26, and then 27 to 43rd trimester. I want you to remember those because when you go into bleeding and other topics later on, we talk about them by trimester. Okay, but how and how they all lined up here. So these symptoms here may happen in the second trimester. There's only like 1 year in the first trimester. So all of the most of the symptoms happen here in the first trimester. Okay. So presumptive means, yeah, I think I'm pregnant, but I'm not really sure. So these are the signs: breast tenderness. Eventually, apart from breast tenderness, it becomes enlarged, and then boundary glands become enlarged, and then the areola gets darker, right? So that's the progression of that. Which hormone is responsible for that again? So that's a trick question because there's 2. Breast tenderness, estrogen, areola darkening, MSH, right? Melanocyte stimulating hormone, very good. And then the GI, you get the nausea, vomiting, but I mean that could be just, I don't know, burritos, maybe 8, right? That doesn't necessarily mean pregnant. But usually 4 to 14 weeks, you have the nausea, vomiting. Amenorrhea, what is amenorrhea? Huh? No period, right? You don't get into bleeding. You know who else doesn't get bleeding? People who are anorexic and bulimic. Because they don't have enough fat. When you don't have enough fat in your body, it messes up your hormones. And so you don't bleed. Okay, also your hyperthyroid case. So it could be that you're pregnant, or it could be that those are some factors. Or maybe you're just stressed. Okay, from school. I don't know. Includes urination, we talked about that. Again, urine enlargement. So I want you to recognize the difference here. This is uterine enlargement, not abdominal enlargement. The uterus, the normal uterus, you can't help it. Okay, it's actually hiding behind our symphysis fetus. Okay, so unless the baby is growing, which is in the second trimester, then it becomes abdominal enlargement. Okay, but you notice this is a different color, so that's a probable sign. Abdominal enlargement is a probable sign. Uterine enlargement is something sign. But there's also quickening here. Quickening, it means that you're feeling the baby move, but this is subject. Okay, so you say, "Oh, I felt the baby move." Well, that could be gas. You don't know, right? But typically, if it is an actual quickening, it's felt in 16 to 20 weeks, or second trimester. Usually by 1st month, you feel the baby move. Okay. So those are all presumptive. I think I'm pregnant, but I'm not sure. It could be something else. probable, you're probably pregnant. So now you're not, the patient is not the only one thinking it, is another person, which is the clinician, saying, you're probably pregnant. How do I know? Let's do these labs. So probable symptoms and signs have labs, okay? It also has all of these fancy names on it. So if you hear a fancy name on an exam, Hager, Hadwick, it's probable sign, right? So probable, you're probably pregnant. Now we're doing urine pregnancy test, UPT, urine pregnancy test. What are we checking for? We're checking for HCG, right? So how early can we detect HCG in the blood? 7 to 8 days. Okay, after the amenorrhea. So let's say you're due to have your period today, you didn't. In a week, you can check the HCG and you'll be positive you're pregnant. Okay. Important thing to remember, might be a test question, you need the first void. Okay, so it needs to be concentrated urine. So it's best for the patient to do it in the morning. You'll go to the lab in the morning, or collect the urine first void. Okay. These other things here we'll talk more about as we talk about other bleeding issues in pregnancy. So this is how it peaks at 60 to 70 days and then actively dying afterwards. Okay. So HCG is probable, and then you have these signs. So Hager and Hadwick. So Hager means that there's softening of the lower part of the uterus. Okay. That is also because of progesterone. Okay. Hadwick sign is the violet bluish color of the cervix. So the vaginal mucosa, the perineum becomes darker. Okay, that's also progesterone and estrogen that's causing that. Okay. And again, there's abdominal enlargement. So now you're seeing the mom is now showing, right? And again, usually they show at 5 months, 20 weeks. Okay. And then there's bloatment. So bloatment is a term that means that when I tap the baby, it floats. Okay, that's bloatment. So bloatment means floating in the baby. Okay. Braxton Hicks is false contraction. So Braxton Hicks is the abdominal muscles and the uterine muscles practicing to contract. But it's false labor, it's not true labor, meaning it's not going to cause mom to have the baby. Okay, so Braxton Hicks contraction is false labor. Leopold's maneuver is a maneuver that we do to feel the baby's position. So this is again a clinician doing the palpation. Okay, so what this is saying is that when the clinician checks the mom, they will feel bloatment. And when they do a Leopold maneuver, they actually do feel a baby in there. Okay, so that's a probable sign of pregnancy. It's not a positive sign because there's only a few signs of positive pregnancy. In the ultrasound, you see a heartbeat. You see a baby, you see a heartbeat, right? In a fetal heart, Doppler ultrasound. So FHR, that Doppler that they also use like for DVT, the same Doppler machine, you put it on the surface of fetus, you will hear a fetal heart rate. Okay, a fetal heart rate is much faster than the mom's heart. Sometimes you can hear the mom's heart rate. So that's a positive sign of pregnancy. Again, all the time you see the fetus in there, and fetal movement felt by clinician. Okay, so again, it's a provider that's feeling the baby move. So those are the only 3 positive signs. Okay. Apart from that, it's either probable or presumptive. Questions? Yeah. Mm-hmm. So they second and third is when we normally would see them. So that's where they're kind of here in the middle. Because like bloatment is 16 to 28 weeks is when they happen. So it could be in between the second and third. Mm-hmm. Yeah. Braxton Hicks usually you feel in the front, in the abdomen. true labor pains, they begin from the back. From like your lumbar area, and then they spread all the way to the front. So it's much more painful. Good question. Anything else?
Okay.
Yeah.
About the same thing. Is it true that vaccine makes more information about the labor and
Absolutely. So, when we talk about labor in week 2, you'll know that Braxton Hicks is very, inconsistent. It comes and goes. When it becomes true labor, the timing of it becomes more consistent. It starts for maybe every 30 minutes, and then every 20 minutes, every 10 minutes, every 15 minutes, until it's every 2 to 3 minutes. That means you're ready to go. Yeah. With Braxton Hicks, you feel it now, and then maybe tomorrow, and then maybe 2 hours later. Yeah, very inconsistent. Any more questions? Okay, cool. Let's see. I wanted to show you. Let me stop this first.